Welcome. In this part of the lecture on the renal system, we're going to talk about acute kidney injury and chronic kidney disease pathologies. Specifically, we'll look at the common etiologies and pathologies of acute kidney injury. You'll notice that I'm calling it acute kidney injury, not acute kidney failure. This is a change in terminology that's important that we make. We're going to talk about how the pathophysiology of diabetes, hypertension, and polycystic kidney disease lead to chronic kidney disease. We're also going to talk about the impact of decreased kidney function on both phosphorus and calcium homeostasis, and then in our summary, we'll review some of the multi-system effects of chronic kidney disease. Let's start then with acute kidney injury. What's important to remember in acute kidney injury, and again, I don't expect you to memorize this definition, but let's talk about concept. So when we think about concept, there are some very specific things I want you to pick up. So in one of the concepts is that there has been an increase in the serum creatinine, and that increase doesn't look really huge, does it? It's only 0.3 milligrams per deciliter, but it goes up within 48 hours, so that's a pretty rapid rise. Or it's an increase in the serum creatinine more than 1.5 times their baseline within the last 7 days. Or it's evidence of oliguria, which would be a urine output less than 0.5 milligrams per kilogram per hour for 6 hours. Now this is very important. In the old days when we thought about urine output, we said it was less than, in an adult, it was less than 30 cc's an hour. We realize that that's not a very good way of looking at that. We need to look at their weight and look at their urine output as it relates to their weight, not just whether or not they're adult or a child. So these are important things to remember. And what's the concept? Serum creatinine is going up and the urine output is going down, and it's in the short term. So what gets us to that point of the acute injury? When we organize our thoughts about acute kidney injury and the things that lead to acute kidney injury, there are 3 major groupings or buckets, you know I love that word buckets, of etiologies: pre-renal, post-renal, and intrarenal. And there are some key concepts in each one of these. In a pre-renal acute kidney injury, the pathology is all about a decrease in the effective circulating volume that's reaching those kidneys. And that's the key concept here. As far as the kidneys are concerned, regardless of what's causing this decrease in the volume getting to them, they're not getting enough circulation. So the biggest things that cause this are volume, hemodynamics, and resistance. So let's think about each one of those pathophysiologic mechanisms. So when you think about pre-renal, if someone has a very low volume state, as far as the kidneys are concerned, they're not getting enough circulation. As a result, then, the body homeostatically and physiologically shunts the blood to those loops of Henle, to those nephrons that have the long loops of Henle. Remember, those nephrons with long loops of Henle are where the juxtaglomerular apparatus lives, and the JG apparatus is where we get renin. So in a low volume state, dehydration, regardless of the reason, whether it's from GI loss or you sweat too much out or from not drinking enough, whatever, that will stimulate the renin angiotensin aldosterone mechanism in order to compensate. Hemodynamics. Is the heart function adequate? That's the big thing on hemodynamics. So you think about pump when you think about hemodynamics. So when I think about, one of the things I think about anyway is pump. So is the heart function adequate? So let's go back to heart failure. If someone has a reduced ejection fraction, that means that hemodynamically the kidneys aren't being circulated enough. So an individual with a decompensated or uncompensated reduced ejection fraction heart failure could develop an acute kidney injury. In sepsis, you also have a hemodynamic effect. In sepsis, because of the systemic inflammatory response and infectious response, there is a decrease in the systemic vascular resistance. With that decrease in the systemic vascular resistance of the septic inflammation, there is massive vasodilation. Well, with that massive vasodilation, once again, there's going to be less blood getting to the kidneys. They're not getting circulated enough, so then they're going to once again stimulate that renin-angiotensin-aldosterone mechanism to try to get more circulation. The third piece is a piece about resistance. So when we think about resistance, remember that there has to be a positive net filtration pressure across the glomerulus in order for that glomerulus to produce a filtrate. So if the oncotic pressure in the capillaries or in the vascular system is greater than the pressure in Bowman space, then you're going to get filtration. If that oncotic pressure in the capillary bed, as reflected by what's in the entire vascular bed, decreases because there's not enough serum protein, then there would be less net filtration pressure, and as a result there's not enough oncotic pressure due to the hypoalbuminemic state to foster that filtration pressure. And once again, kidneys sense that they're not getting enough circulation, and they will develop a pre-renal acute kidney injury. So when you think about pre-renal, I want you to focus on the effective circulating volume, and I want you to think about where the pathology is. The pathology is not in the kidneys. If you restore an effective volume in a pre-renal AKI, the kidneys will recover. In a post-renal acute kidney injury, we're talking about backward pressure, so that there is too much pressure after the glomerular filter in order to foster filtration. So when you think about backward pressure, this pressure can be inside the system or it can be outside the renal urinary system. So if it's inside the urinary system, think about a male who has a very large prostate gland that is squeezing off the bladder outlet. Well, remember that urine is going to follow the path of least resistance. So since it can't get out, the bladder will fill, the urine will reflux into the ureters then will reflux into the collecting system, collecting ducts, tubules, and now you've increased the amount of pressure in Bowman space. Since you've increased all of that pressure in Bowman space, once again, you've lost your net filtration pressure in order to do the filtration. Now, outside the renal system, the concept is the same, except something is pressing on usually the ureters, or it could be also a bladder outlet, but pressing on the ureters that is not allowing the urine to exit from the kidneys. When this happens, then once again you're going to get backward pressure in the collecting system. So when we think about things outside the system that could squeeze those ureters shut, first off, remember, in order for this to cause an acute kidney injury, it has to be bilateral. So if I close off one ureter because the woman is 9 months pregnant and the fetus is laying against one of the ureters and won't move, then the other kidney is going to take over. And while there may be hydronephrosis on that affected side, she doesn't experience acute kidney injury because the other kidney takes over. But what about a very large ovarian tumor or a very large colon cancer, where the tumor mass is so big that it's obstructing outlet from the renal pelvis? That could cause bilateral backward pressure and an acute kidney injury. Once again, let's think this through. Where's the pathology? Pathology's not in my kidneys, because it's the backward pressure from the other forces that are causing the kidneys to get into trouble. Now the third type or pathophysiologic etiology is intrarenal. Now the pathology is in the kidneys. And this can be either due to basement membrane or tubular epithelial membrane damage. So remember, if the basement membrane remains intact, there's a higher probability of recovery than if the basement membrane breaks down. So that's why we always want to get on top of any kind of acute kidney injury, because if a prerenal or a postrenal continues to build over time, it can become prerenal. So when we look at an intrarenal etiology, we look at both glomerular as well as tubulo-interstitial pathologies that could be causing an acute, severe decrease in kidney function. Now, when we look at those pathological mechanisms of the acute kidney injury, there are usually some fairly common pathophysiologic steps. Something has to get this started. So you have an initiating factor. In prerenal, it may be hypovolemia. In postrenal, it could be that prostate enlargement. In intrarenal, it could be a nephrotoxic drug injury. That initiating factor will lead to both renal and cortical ischemia, so a lack of oxygen is getting to those tissues. When those tissues become ischemic, that's going to lead to constriction in the vascular structure of the glomerulus. So you're going to have glomerular vasoconstriction. Those little vessels are going to start to close down. Now, with that glomerular vasoconstriction, the glomerular filtration rate will decrease. If you decrease the GFR, you will decrease the amount of flow through that tubular lumen. If you don't have flow through the tubular lumen, then you don't have any urine, therefore oliguria. And that's an important piece to remember. When this occurs, this tends to occur in some fairly stepwise steps. So first you have the initiating factor. This is something that we really want to keep our eyes open for, because AKI is always a complication of something else. There's another pathology going on that's negatively affecting those kidneys. So early on in that initiating phase, you're going to have someone who is at risk because of their other disease processes, and you start really keeping their eye on, and you do everything you can to prevent. But if this gets started, many of the AKIs will lead to an oliguric phase where there is a decrease in the urine output. Now there are some non-oliguric etiologies of acute kidney injury. The most common non-oliguric that I can think of are some of the nephrotoxins. Specifically, aminoglycosides are usually non-oliguric. Following oliguria, hopefully, they will enter the diuretic phase. The diuretic phase is the first sign that they're beginning to recover. Now, the key to this phase, in the diuretic phase, is the urine-specific gravity is fixed. Remember that our urine-specific gravity, which is a reflection of the concentration of our urine, is constantly fluctuating between that 1.005 to 1.010 or 1.015. In this diuretic phase, that specific gravity doesn't fluctuate very much because the tubules haven't yet recovered the reabsorptive and secretion functions. So their filtration is coming back and they're starting to make that primary urine, but because the tubules need more time to recover, reabsorption and secretion hasn't come back, therefore the specific gravity doesn't change. And then last but not least is the recovery phase. This recovery phase can last a few weeks to several months, highly variable. All of these phases, initiating, oliguric, diuretic, and recovery, do not have fixed time frames. However, the longer the oliguric phase, the poorer the prognosis. the shorter the diuretic phase, the better the prognosis because the tubules are recovering. So let's look at some pathologies specifically. Acute tubular necrosis. We throw this phrase around a lot, especially when we're talking about acute kidney injury, and they'll say, oh, they've got ATN. Well, acute tubular necrosis can be due to a variety of mechanisms. It can be ischemic, like we just, we'll talk about a little bit more, but we kind of opened the door to that. It can be related to nephrotoxins, and these nephrotoxins can be either endogenous or they can be exogenous, coming from the outside. And then an acute tubular necrosis can be due to the immune response. When we did the immune system, we talked about kidney transplant rejection. This is a post-organ transplant rejection that we already talked about, remembering that this is a T-cell mediated immune response that can alter the kidney function and can lead to an acute kidney injury, or if it isn't resolved, can lead to graft failure. First, let's take a look at the ischemic response. In an ischemic injury, and one thing that I want you to remember is physiologically, our kidneys already work, especially our tubules, already work in a relatively hypoxic environment. So what happens in an ischemic injury, long-standing pre-renal or anything that decreases that blood supply, the microvasculature begins to constrict. In that as a result of the microvascular vasoconstriction, there is also a poor response to our normal counter-vasodilator biologic mediators. So you've disrupted that response to our endothelium being able to vasodilate. This then leads to injury in the vascular smooth muscle and stimulates both coagulation as well as inflammatory mediators. So you're getting the idea here once again that one of the things we have to think about in ischemic injury is inflammatory injury. Because you have vascular smooth muscle injury and you have vasoconstriction, this leads to hypoxia at the cellular level and decreased delivery of nutrients and removal of waste products. Cells that don't get oxygen and cells that don't get fed tend to die. Therefore, you will have untimely apoptosis or cell death, and the cells also begin to become necrotic. With that cellular necrosis, the tubules will then be obstructed because those endothelial cells begin to slough off. Remember the tubulointerstitial injury? When you have the sloughing of those endothelial cells, you're going to get back leak from the lumen of the tubule into the interstitium, and as that interstitium gets more and more fluid and junk into it, it's going to physically, potentially, not only do you have tubular obstruction in the tubular injury because of those endothelial cells, but you can also have external collapse of the tubular lumen because of the interstitial fluid collection, or just they start breaking down. The interstitium will break down. One of the most common pathologies we have that leads to acute kidney injury is related to nephrotoxins. With nephrotoxins, this can be from a direct cellular destruction from one of our own products of physiology. It can be hemoglobin, as in a transfusion reaction. It can be myoglobin, as in a rhabdomyolysis, or which results from severe crush injury. So the direct tubular destruction, when you look at hemoglobin, the free hemoglobin is directly toxic to tubular cells. Myoglobin is released, and generally myoglobin can initially be reabsorbed. But when you have massive release of myoglobin from muscle cells being destroyed, the tubules aren't able to reabsorb all of it, and therefore it becomes a direct toxin. You can also have direct cellular injury from exogenous substances like metals or chemicals. Think direct cellular injury. So what about drug-induced nephrotoxicity? The primary pathologic mechanisms in a drug-induced nephrotoxicity are hemodynamic, glomerular, or tubular. So when we think about hemodynamic toxicity, the drugs that can come to mind include ACEs and ARBs. With an ACE and an ARB, you have altered the hemodynamics within that capillary bed, because remember, when you inhibit angiotensin, either the enzyme or the receptor, you now have changed the hemodynamics within the glomerular capillary, within the capillary vasculature. NSAIDs, non-steroidal anti-inflammatory drugs, as a class effect, whether it's aspirin or whether it is ibuprofen, naproxen, they block the vasodilating prostaglandins. Remember that prostaglandins in the kidneys are local vasodilators. If you block them, you now have blocked vasodilation, therefore you're going to see constriction. In the glomerular toxicities, generally these are due to an effect of the drug to increase permeability in the glomerular membrane. This is what lithium does, this is what heroin does, and once again, non-steroidal anti-inflammatory drugs can increase glomerular permeability. The third and most common type of mechanism is a tubular mechanism. And in the tubular mechanism, you'll see this with an antibiotic, especially the aminoglycosides, but you also see this in iodine contrast, and once again, those non-steroidal anti-inflammatory drugs. Non-steroidal anti-inflammatory drugs can actually be directly cellular toxic. Now, the final type of nephrotoxin pathology is an interstitial nephritis. This by far is the most common pathology or pathologic mechanism. In an interstitial nephritis, this is primarily due to to nephrotoxic drug. What happens is the drug binds to the tubules, the tubular cells, and actually becomes an antigen. That's why they call it a hapten. So a hapten is a substance that normally we don't think of as an antigen, but it becomes an antigen. The usual manifestation of an interstitial nephritis, because this is essentially an antigen-based response, is an allergy-like response. So you'll see eosinophils in the circulation as well as in the urine. Your patient may develop rash and itching. That's why you always ask about what their drug allergy was. And usually manifests within 30 days of being on the medicine. When it manifests, what do you think you do? Sure, take them off the drug, and it usually reverses. Non-steroidal anti-inflammatory drugs are tricky devils. First off, non-steroidal anti-inflammatory drugs cause an interstitial nephritis that does not look like allergy. In an NSAID interstitial nephritis, rather than seeing the eosinophil response and the rash and the itching like that allergy response, you tend to see an increase in protein in the urine. You see an elevated potassium in the serum, and you tend to see more volume overload, especially in elders. also that is very different. So not only is the manifestation different, but the time frame is different. In an NSAID-induced interstitial nephritis, the time frame is extremely variable and may take up to a year. So you can't outlaw nonsteroidals in an interstitial nephritis if they take them. The population that is especially at risk to NSAID-related interstitial nephritis, this nephrotoxin pathology, are elders. They tend to exhibit more protein in their urine, more hyperkalemia, and more hypertension than others with an NSAID pathology. Let's turn our attention now then to chronic kidney disease. Now you'll see that the definition, the diagnostic criteria for kidney damage, for chronic kidney disease is quite different than for acute kidney injury. And you can see there that we're looking for structural or functional abnormalities of the kidneys with or without a decrease in the glomerular filtration rate. And this may show up either as a pathologic abnormality or through those markers of kidney damage. So it can be structural or functional, but note that the damage has to be present for a minimum of 3 months. Anytime the GFR decreases below 60 milliliters per minute for more than 3 months, whether they have structural or functional damage, they have CKD. And when we look at diagnosing CKD, we look at 2 parameters. We look at the glomerular filtration rate, and we look at the amount of albumin in the urine. And these are the clinical practice guidelines, and I've referenced them. So what do I want you to remember as we talk about these diagnostic criteria? I want you to look at time frame, and I want you to think about the significant change in their GFR and the amount of albumin in the urine. So when we look at kidney disease, we grade the severity of the kidney disease. And you can see that the grade of the severity is based on the glomerular filtration rate. As long as the glomerular filtration rate is equal to or greater than 90, they're doing pretty well, but they may have kidney damage, so that would be grade 1. If they have no kidney damage and they have a GFR greater than 90, they don't have kidney disease. At grade 2, you can see that the GFR is dropping. Grade 3 is split into 2 categories because this is a very active phase when the GFR is dropping below 60, and that's why they split it out into 2 different grades, because so much is happening to the kidneys. In grade 3A and 3B, when that GFR drops below 60, this is when you start seeing the some of the systemic effects of the chronic kidney disease. In grade 4, you can see how severely affected the GFR is. But for most of these individuals, even though their GFR, their kidney function has decreased quite a bit, they're still able to maintain homeostasis. But they're starting to see problems with bone disease. Anemia that may have been on the edge, that anemia of chronic illness, is worsening. And then we have grade 5, and we also have some people also include the grade 5D. Grade 5D is when the patient has a GFR equal to or greater than 15 and is on dialysis. There are individuals with GFRs or 12, 13, or 14 that are able to stay off dialysis. So as we look at those things again, let's look once more, let's review that in grade 3, this is an incredibly active pathophysiologic category because that's when we're beginning to see those systemic effects of decreased kidney function. In grade 4, things are definitely getting worse, and this is when we start getting people ready for kidney replacement therapy. This is also the stage where potential nephrotoxins have to be watched very carefully, and kidneys that do have to be, drugs that have to be renal dosed have to be decreased in dose, or the time between the doses has to be increased, simply because of this pathology. In grade 5, clearly they are beginning to lose homeostasis. One phrase that I strongly encourage you to abolish completely from your terminology is renal insufficiency. That phrase needs to go away. It is not diagnostic. It isn't even descriptive. We need to specifically say what we're talking about. What is their serum creatinine? Preferably, though, what is their GFR? Because that's one of the things that really matters. The second thing we look at when we look at chronic kidney failure or chronic kidney disease is the amount of albumin in the urine. Not all patients have albumin in their urine. However, as it becomes increasingly advanced, the probability becomes greater and greater. As a result, then, when we classify chronic kidney disease, we talk about their GFR and their albumin category. Once again, understand the concepts. As the GFR drops, their kidney function is worse. As the amount of albumin in the urine goes up, or that albumin to creatinine ratio goes up, their kidney function is worse. Remember that CKD may be due to primary kidney pathologies or secondary to other pathologies. Those primary kidney pathologies we talked about glomerular and tubulointerstitial diseases. We're going to talk about polycystic kidney disease, which is a primary kidney pathology. Or, very commonly, the vast majority of chronic kidney disease is due to secondary causes. The two big ones are diabetes and hypertension. But we also know that CKD can be due to cardiovascular disease, poor heart function, especially heart failure. So let's take a look at some of these pathologies that cause chronic kidney disease. Worldwide, as well as in the United States, the leading cause of end-stage kidney disease is diabetes-related nephropathy. As we talked about previously, we know that the glycated end products of glucose metabolism are pro-inflammatory. In the glomerulus, and this is a glomerular pathology that has both inflammatory as well as non-inflammatory pathology. The strong non-inflammatory has to do with the vessel damage from those glycated end products. We know that one of the most important things that we think about with diabetic nephropathy is the afferent and efferent arteriole. With the vascular pathology, there is an increased amount of pressure within that glomerulus. As a result of the increased pressure, because the afferent is constricting and the efferent is constricting, it damages the basement membrane of that glomerulus. Therefore, what would be the hallmark symptom or the manifestation of diabetes-related nephropathy? Yes, protein, albumin in the urine. This is why individuals with diabetes need to have an annual urine specimen for albumin, and the albumin to creatinine ratio needs to be calculated to determine whether or not the kidneys are being affected by their diabetes. Now, when we look at both type 1 and type 2 diabetes, both carry the risk of diabetes-related nephropathy. As I previously mentioned, the hallmark is a small amount of albumin that progresses to obvious proteinuria and potentially nephrotic syndrome. In type 1 diabetes, about 40% of patients will experience diabetes-related nephropathy. However, the onset is usually about 10 to 20 years following diagnosis. Now, part of this is because we diagnose type 1 diabetes earlier, and so they have a longer trajectory because of that. In type 2 diabetes, 40 to 60% of individuals with type 2 diabetes will develop the complication of diabetes-related nephropathy. For many individuals, they already have nephropathy at the time of diagnosis. It isn't because it is more aggressive in type 2, it's because we don't diagnose type 2 very early. And so they've had diabetes for a while before they're ever diagnosed. The other thing about this albumin in the urine, the albuminuria is not linear. It tends to fluctuate early in the disease, but even after it is present, doesn't have a linear time and amount progression. In diabetic nephropathy, because this has a strong element of a vascular pathology from the pressure, you have microvascular damage with glomerular changes. Now, initially, the kidneys respond by hyperperfusing and hyperfiltrating. When that happens, the mesangium, especially in type 1, expands. And that mesangium, remember, are the supporting structures. But over time, the basement membrane becomes thicker, and that's what we really see in type 2 when we see these patients. There was an excellent study done quite some time ago, and this is the Advance-On study. The Advance-On study looked at the long-term benefits of intensive glucose control to prevent end-stage kidney disease. And they looked at this in type 2 diabetes. They had a really good sample size. They had about 8,500 subjects, and they followed these individuals for an average of 5.4 years. What they identified is that the effects of diabetes control were greater in early stages of CKD and in lower baseline systolic blood pressures than in later stages of CKD with individuals with high systolic blood pressures. There was no risk, so that intensive glucose control did not make any difference in terms of the risk of death, cardiovascular death, major cardiovascular deaths by level of kidney function. So what does that tell us? What that tells us is, in order for intensive glucose control to prevent end-stage kidney disease, we need to get their diabetes under control early before it has a chance to cause not only kidney damage but other systemic damage. The risk of developing diabetes-related nephropathy increases with a A1C greater than 7% and a blood pressure greater than 150/85. So what about hypertension and the effects on the kidneys? This is a primarily non-inflammatory glomerular pathology of vascular pathology. Hypertensive nephropathy or hypertension-related nephropathy is the second most common cause of end-stage kidney disease. The hypertensive nephropathy or hypertension-related nephropathy is due to the process of atherosclerosis and the resulting vascular changes that lead to sclerosis of that glomerular membrane. So once again, you have a lot of pressure within those glomeruli. The hallmark symptom of hypertensive nephropathy is protein with cast. Now, the protein in hypertensive nephropathy is not as high as you will see in most nephrotic syndromes. So you won't usually see 5 or 6 grams, but you may see 2.5 to 3 grams of protein in the urine. But we look very closely for that renal sediment. What are those cast-off cells that show up in the urine telling us? The signs and the symptoms are going to vary with the degree of severity of their hypertension. So the problem we have with hypertension-related nephropathy is the kidney damage is generally silent until it advanced. We know that hypertension-related nephropathy progresses more rapidly in African American males, and we suspect this is because of the kidney protection mechanisms in African Americans to protect their vessels are not as active in that ethnic group. So I promised you we would talk about polycystic kidney disease. This is a primary kidney pathology that leads to chronic kidney disease. Polycystic kidney disease is an autosomal dominant kidney disorder, genetic disorder. The autosomal dominant is overwhelmingly the most common form of the disease. There is also a recessive form of the disease, but is not seen nearly as often. So I'm going to focus on autosomal dominant. So when we look at this genetic alteration, what we're looking for are alterations in PKD1 and PKD2. PKD2 is polycystin, and this is a protein. PKD1 and PKD2 helps transport calcium into the cells. In addition, polycystin regulates the growth and the differentiation of that tubular epithelium. So this genetic defect alters, leads to insufficient activity of polycystin. Remember, that's useful in transporting calcium into the cells, but that polycystin is a growth regulating factor that helps differentiate those tubular epithelium. Now, autosomal dominant PKD, ADPKD, autosomal dominant polycystic kidney disease is usually manifested during the 30s and the 50s. So an individual has entered their young adulthood or their early middle age. As a result, then they may already have had their children, and they may not know that they're carrying this genetic disorder. The way this lack of polycystin gives us trouble is that multiple cysts form within the kidneys. And remember, this is in the tubular epithelium. As a result, then, the tubular epithelium begins to expand, and you have stretching and narrowing of the vessels within the kidneys, the intrarenal vessels. Because of the stretching and the narrowing, that then leads to ischemia, and the ischemia stimulates the renin-angiotensin-aldosterone mechanism. That's why the most common manifestation of this disorder is hypertension. And in evaluating the hypertension, we identify the polycystic kidney disease. When you do an ultrasound, you see the polycystic kidneys. In some cases, individuals will present with back pain because these cysts that develop stretch the kidney capsule, that renal capsule. Remember, the kidneys are covered by a tough fibrous capsule. It's there to maintain homeostasis should there be injury. However, if you have all of these cysts growing and those cysts are space-occupying lesions, it's going to stretch that capsule. In addition, those cysts, these multiple cysts within the tubules, become obstructive and can rupture and hemorrhage. And when it does that, they rupture into the parenchyma, or the supporting structures. The larger the kidney becomes, the greater the pathology and the greater the likelihood that this will lead to end-stage kidney disease. So that's why when we uncover polycystic kidney disease, we start investigating family history, and we identify whether or not other individuals in their family are not only at risk, or whether they already have polycystic kidney disease, so that we can follow them carefully. Once again, there is not a specific linear time frame as it regards to how quickly the end-stage kidney disease develops. So it takes ongoing evaluation. Because this is a genetic disorder, even these patients can be transplanted, and the disease does not recur in the transplanted kidney. One of the two major systemic effects of chronic kidney disease have to do with bone mineral metabolism and cardiovascular disease. Remember that in normal pathology, the kidneys are responsible for synthesizing 1,25-dihydroxycalciferol, and we need this hormone for vitamin D metabolism. The decrease in the synthesis of the hormone begins as early as stage or grade 2 CKD and is definitely accelerated in stage 4 when that GFR is below 30. In the absence of activated vitamin D, which is D3, calcium is not absorbed efficiently. And remember, most of our calcium absorption comes from the GI tract. When we don't absorb calcium from the GI tract, the body will take the calcium out of the bones. So because the kidneys aren't reabsorbing any of this calcium, this leads to a decrease in the plasma calcium and a reflex increase in the phosphorus level. When you increase that phosphorus level and you have a decrease in the calcium level, that stimulates the parathyroid hormone. Under the influence of parathyroid hormone, and you stimulate that, the idea was to increase the serum calcium. However, remember the phosphorus levels are still very high because the calcium level is low, and so the parathyroid glands continue to tell the body, increase the calcium level, but the body can't do that because they don't have the 125 and they're not able to absorb. So the end result of this mineral bone metabolism defect is that it has both negative bone as well as cardiovascular effects. That bone turnover is being altered. And so as a result, either there's that parathyroid hormone continues to encourage the bone to put out more calcium, but we're still not able to use it, and so this leads to significant bone disease and elevated parathyroid hormone levels and elevated phosphorus levels. At the same time, this calcium that we do have continues to circulate because we aren't able to use it effectively. And this has negative cardiovascular effects. When we look at cardiovascular disease in chronic kidney disease, one of the things we want to remember is what kills patients with chronic kidney disease. Cardiovascular disease. And actually within cardiovascular disease, sudden cardiac death is more common in this population than in the general population. But when we look at the vascular disease that contributes to the cardiovascular disease, we have to think about a fairly large number of variables. Certainly with cardiovascular disease, individuals with chronic kidney disease exhibit dyslipidemia and hypertriglyceridemia. Individuals with chronic kidney disease tend to have fairly high triglyceride levels, especially type 4 triglycerides, because of altered lipid metabolism. When you think about anemia, certainly this could lead to an ischemic process and hypoxia-related chest pain. Because these individuals are very anemic, remember kidneys produce erythropoietin, and erythropoietin is the primary stimulus to produce red blood cells. If they're not producing enough red blood cells, the anemia can become extremely severe, and if they already have ischemic vascular disease, they will have hypoxia-related chest pain. Hypoalbuminemia also increases the risk of death in cardiovascular. It increases the risk of death overall, as well as adverse drug reactions, because remember, many of our drugs bind to proteins. Hyperparathyroidism and the alterations in bone mineral metabolism that we just talked about lead to calcification of the arterial media, as well as calcification of the valves. Now, this is an important thing to remember, because in the calcium effects of the mineral bone metabolism, this affects the arterial media. Atherosclerosis, the dyslipidemias, affect the intima of the vessel. Most of our patients with chronic kidney disease, especially in grade 4 as well as into grade 5, have a lot of problems with volume overload, which then leads to heart failure. They may have initially preserved ejection fraction that then may progress to reduced ejection fraction heart failure. And last but not least, the uremic environment is pro-inflammatory. That uremic environment being pro-inflammatory further complicates the atherosclerosis, the bone mineral disease, the development of anemia, and further decreases the serum albumin. So what do I want you to get out of, before I summarize, what do I want you to get out of this piece? Can you describe the 3 pathologic mechanisms of acute kidney injury? Do you have a sense of the importance of glomerular filtration rate and albumin levels in CKD, that key being less than 60? Can you walk me through the effects of diabetes and hypertension on the kidneys? Can you describe polycystic kidney disease? What is it? Why does it happen? Autosomal recessive disorder. Autosomal dominant disorder. Can you tell me how that polycystin leads to the cyst formation, and how would those cysts manifest? And then importantly, can you think through the effects of chronic kidney disease on multiple systems? Anemia of chronic illness, acid-base balance. What would their acid-base balance be? Yes, they have a chronic metabolic acidosis. In the GI tract, the GI system isn't terribly fond of this, so they may develop peptic ulceration. They may develop uremic gastroparesis. In the cardiovascular range, we talked about the increased risk of sudden cardiac death, of MI, of cardiovascular disease due to dyslipidemias and vascular calcification. In homeostasis, in our response to infection, in the uremic environment, not only are the red cells have a shorter lifespan, but our phagocytes are slower, and they are less effective in engulfing bacteria. There isn't a body system that chronic kidney disease doesn't negatively affect and can lead to additional pathologies. Please let me know if you have questions, and I appreciate your attention.